Let's get right into the algorithmic approach to perioperative medicine and anesthesia complications for Step 2 CK. You need strict next best step logic here to navigate surgical risk assessment, selective testing, and intraoperative crises. Here's our agenda. 1. Preoperative testing. 2. Cardiac risk and valves. 3. AFib and anticoagulation. 4. Malignant hyperthermia. 5. Specific anesthetic traps. And 6. Emergence complications. Let's jump in. Section 1. Preoperative testing. Avoid routine orders. Do not order a standard panel of tests for every surgical patient. The boards will test you on this. Testing has to be completely based on the patient's underlying comorbidities, their current symptoms, the specific surgical risk level, and the expected blood loss. Every single test you order must have a concrete clinical justification. So when do we actually pull the trigger on these tests? For an ECG, you need a history of coronary artery disease, an arrhythmia, or an asymptomatic patient with an elevated major adverse cardiac event, or MACE, risk of 1% or higher. For a chest X-ray, you're ordering that if there's a history of cardiopulmonary disease or if they're undergoing upper abdominal or thoracic surgery. You check hemoglobin if there's a history of anemia, significant expected blood loss, or major surgery. And you order coagulation studies and platelets for a history of abnormal bleeding, liver disease, anticoagulant use, malignancy, or, and this is a big one, a planned spinal anesthesia. Section 2. Cardiac risk and valves. The decision tree. When you're managing valvular heart disease before non-cardiac surgery, your first branch point is figuring out if the dysfunction is mild or if it's moderate to severe. If it's just mild dysfunction, you generally proceed to surgery. For moderate to severe disease, you have to evaluate their symptoms. Severe symptomatic disease or valve-specific high-risk criteria usually means you need a valve intervention before that elective surgery. But if they are asymptomatic or have very minimal symptoms and the surgical risk is low, you can often proceed safely. Section 3. AFib and anticoagulation bridging. Stable versus unstable. If a patient with preoperative atrial fibrillation is hemodynamically stable and completely asymptomatic, simply continue their prior rate or rhythm control medications and address their anticoagulation. If they are stable but the rate is uncontrolled, achieve rate control using a beta blocker or a non-dihydropyridine calcium channel blocker. But here's the shift. If rate control fails, or if the patient is acutely unstable with hypotension, syncope, chest pain, or heart failure, use synchronized electrical cardioversion and delay the elective surgery to treat those underlying causes. Interrupting anticoagulation is entirely driven by surgical bleeding risk versus thromboembolic risk. For a direct oral anticoagulant, you usually stop it the day of a minimal risk surgery or 1 to 3 days before a higher bleeding risk surgery without bridging. For a vitamin K antagonist like warfarin, stop it 3 to 5 days before the procedure. Low thromboembolic risk generally doesn't need bridging. Bridging is strictly reserved for high thromboembolic risk, like a very high CH2-DS2 VAS score, a recent stroke, or a mechanical valve, provided they don't have a prohibitive bleeding risk. Section 4. Malignant hyperthermia. Intraoperative crises. Malignant hyperthermia is a genetic disorder of defective intracellular calcium control. The classic triggers are volatile anesthetics, succinylcholine, and excessive heat. The most reliable early sign is a rising end-tidal CO2, or hypercarbia, that's resistant to increased minute ventilation. This progresses to masseter, or generalized muscle rigidity, sinus tachycardia, rhabdomyolysis, hyperkalemia, and acidosis. Hyperthermia is actually a late finding. If you see this, stop the trigger immediately, provide ventilatory and respiratory support, start active cooling, treat the hyperkalemia, and administer dantrolene. You have to strictly distinguish malignant hyperthermia from neuroleptic malignant syndrome. Malignant hyperthermia is triggered by anesthetics and evolves rapidly over minutes in the operating room. Neuroleptic malignant syndrome is triggered by central dopaminergic blockade from agents like haloperidol or promethazine, and it evolves slowly over a period of days. In patients with severe skeletal muscle trauma, major burns, or stroke, denervation causes a massive upregulation of acetylcholine receptors at the neuromuscular junction. Giving succinylcholine to these patients hits those extra receptors and triggers massive potassium efflux. That leads directly to hyperkalemia and cardiac arrhythmias. Section 5. Specific anesthetic traps. Contraindications. Two big anesthetic contraindications here. Nitrous oxide inactivates vitamin B12. Giving it to a patient with an underlying B12 deficiency will quickly precipitate or worsen severe neurotoxicity. Second, propofol is a profound myocardial depressant. Using standard induction doses in a patient with severely reduced left ventricular systolic dysfunction will induce severe hemodynamic collapse and hypotension. Section 6. Emergence complications. Post-operative recovery. A post-dural puncture headache happens after a lumbar puncture or neuriaxial anesthesia. The defining feature is positional. The headache is intensely worse upright and dramatically improves when supine. You might also see neck stiffness, photophobia, diplopia, hearing loss, or tinnitus. It's often self-limited, but the definitive treatment for severe or persistent cases is an epidural blood patch. For delayed emergence, where the patient is somnolent beyond expected recovery, you have to evaluate oxygenation, metabolic derangements, neurologic insults, pain control, and bladder distension. Emergence delirium is the opposite, a hyperactive, agitated state in the OR or PACU. It's usually a temporary reaction to volatile anesthetics. Your next best step is to reassure and reorient the patient while rapidly excluding those dangerous causes.